Hello, everyone. I see we've got quite a few people in here. Welcome to NPA's Neuroplasticity Brain Awareness Week Boot Camp. It's our Learn to Learn series, and we'll get started here in just a few more minutes. We've got another minute or two before I want to get started. So take a minute, grab your lunch, and get ready. All right. Well, it's 12:02. I think we'll go ahead and get started. So again, thank you everyone for being here. I'm so glad that you decided to join us and share your lunch hour with us. It is Brain Awareness Month, the whole month of March. And this week is actually Brain Awareness Week. So that week is been created to help bring awareness and education to those individuals who are caregivers or patients and who are interested in learning more about the brain and how to care for it. And as part of that initiative, NPA is hosting a week-long boot camp series to highlight neuroplasticity professionals, people who are applying the principles of neuroplasticity and using those to help individuals who have neurologic dysfunction in some way, shape, or form, such as learning differences or a brain injury, or stroke, or exposure to neurotoxins, long COVID, chronic fatigue, and chronic pain. So it is a broad spectrum, and our speakers, we have 5 speakers, one each day for this Lunch and Learn, and they're going to be sharing their protocols with you, but then each one is volunteered to share a specific exercise that you can do at home that will treat certain symptoms of and using neuroplasticity. And they'll walk you through those, and hopefully those will be beneficial and you'll find some value in that. Want to, before we get into introducing our speaker, who is joining us here in just a few minutes, I want to give you just a little bit of background about NPA. NPA is a not-for-profit. We're a 501c3, and we were created to help generate awareness, access to, and development of applied neuroplasticity therapies. These therapies are really life-changing. I came to this, I'm the executive director and the founder, and I came to this as a result of finding neuroplasticity-based therapies that help my family, several members of my family, my daughter and my mother in particular, who were suffering with different neurological challenges, learning differences, and multiple sclerosis. And after years and years of trying to help them find therapies that would allow them to thrive, I ran across several different neuroplasticity-based therapies, tried them, and had a miraculous level discoveries. And that includes depression for one of my other family members. So I hope that you'll find value in this. It's my goal and my mission to help share this information so that people in similar situations to myself can also benefit. So you can find a little bit more about NPA on npaallies.org. It's npallies.org, and you will learn a little bit more about our mission and what we're doing there. And as I mentioned, we are a 501c3, so any donations to help us continue to put content out like this will certainly be appreciated. So I want to take a few minutes and also introduce our speaker, Alina, Dr. Alina Fong. And let me see, Alina, are you here? Have you joined? I do not see her in here in the panel. Let me just check and make sure all is well on her end. Okay, looks like she's joining in now. All right. So let me just give you a little bit of background about Dr. Fong and CognitiveFX. And so Dr. Alina Fong is, she is a clinical neuropsychiatrist, and she is the founder and clinical director for CognitiveFX. They are located in Provo, Utah. And Dr. Fong, she, after getting her PhD, did her residency in Salt Lake City at the Veterans Hospital there. And during that time, the Iraq and Gulf Wars were going on, and a lot of the veterans were coming back with brain injuries and PTSD, and they knew something was wrong, but really couldn't quite diagnose that. And she was able, through her use of neuroimaging, which she has a specialty in neuroimaging as well, she was able to use that and hone her skills as a clinical neuropsychiatrist to create a protocol that would help these veterans and really return them back to their full life. She really leveraged a multimodality approach. So that was using physical therapists, occupational therapists, and physicians, psychiatrists, MDs, and a whole range of other professionals, which she has grouped together now within CognitiveFX. And she is going to walk us through that. And I am it looks like she's joined, but she's not quite in the system. So give me just a minute to see where she is here and see if we can get her on board. Okay, everyone, sorry for that. Dr. Fong is going to join us here in just a second. There was an issue with the link and for her to get in, and here she is now joining us.
Hi, I'm so sorry. I must have had the wrong link.
Yeah, apologies on my end. I had corrected it last night, but I guess anyway, that is on me. Dr. Fong, welcome. You have been introduced, and we have a good round of participants here who are sharing their lunch with you today.
Thank you. Thanks for having me.
Yeah, so Dr. Fong, like I said, I went ahead and gave a good overview of your background and CognitiveFX, but I thought maybe we would go ahead and start with just a little bit of Q&A, if you're ready for that.
Sure. Yes, let's do it.
Okay, great. Yeah, so you did your residency at the VA hospital, and I know that's kind of where you developed your passion for treating brain injury, and you have a background with a specialty in neuroimaging. And I understand that's kind of really the unique function around CognitiveFX and how you intertwine those two to create a very different protocol than that's out there on in the market. So what would you maybe take just a few minutes and sort of ground everybody in what your protocol looks like and kind of maybe what a patient would experience as they go through that? So what's different about CognitiveFX, and what would a patient go through if they came in?
So thank you so much, Sherry, for the introduction. The best way to explain why CognitiveFX is so different and so special is that we really do specialize in these more complicated cases. So we specialize in these patients that, maybe have struggled with brain injury for, sometimes years, sometimes decades. And their symptoms can be quite broad and can be quite difficult for maybe other clinicians or practitioners to kind of wrap their heads around. We really do specialize in that patient that has the dysautonomia, that has the vision vestibular issues, has a lot of these other types of cognitive symptoms, sleep issues, and then also maybe even some psychological symptoms now. It just can become a real complicated ball of symptoms that it can be really daunting to try to unravel. And so one of the biggest tools that we have, and one of the best tools that we have, is functional MRI. So let me explain what fMRI is in general.
Yeah, good.
Yeah, that'd be probably a good idea. So regular MRI is just like a snapshot of the brain, right? In fact, many of your listeners probably have had regular MRIs. You could have it of your brain, your wrist, your whatever it is, your heart. And that's great to make sure that there's nothing organic or really major going on with the brain. But most of my concussion patients, even these chronic ones, have normal brain MRIs, right? One of the diagnostic criteria is normal MRI scans of a concussion. So one of the diagnostic criteria of a concussion is just having a normal MRI. Unfortunately, that's where a lot of clinicians say, okay, it's normal, I guess you're fine, you know? Well, we take it a step further. So in the fMRI, they're still inside of a regular MRI machine, but they are doing cognitive tasks while they're in the MRI. They're doing memory tasks, problem solving, focus, attention, multitasking tasks. And while they're in the MRI machine, we can actually see how their brain is activating, which parts of their brain are functioning well, which parts are maybe not firing as much, which areas are overcompensating and over communicating and kind of taking resources away from other structures as well. And so it's a much more active and functional way of looking at the brain, you know, and this is really where we see a lot of the deficits, because someone can look completely normal, but when they are doing this task, we can actually see that their brain is firing very inefficiently, even though they can answer the right questions on a regular test. So really what I like to say is that the fMRI shows what it's costing you to do these things, not just whether or not you can do them. Because I know that many of my patients can pour themselves a bowl of cereal. They can, you know, make something if they need to. They can drive themselves to the grocery store. But what we're not capturing is what it's costing that patient brain-wise in order to do that.
Yeah, so it's a real-time analysis to determine not only the function, whether it's functioning or not, but the efficiency and the level in which it's functioning.
Exactly.
Yeah, and so, no, go ahead. And so that you combine that, then there's a physical assessment that goes along with that, which helps you then determine what your treatment plan is?
Sure, yes. We have a number of therapists in the clinic. So we have PT, we have physical therapists, neuromuscular therapists, occupational therapists, vision, vestibular, we have psychologists, we have, you know, nurse practitioners. I mean, we have so many different modalities of therapists and clinicians, and they each are doing their own type of evaluation as well. So the fMRI really just clarifies treatment for us and helps the therapists be able to, you know, really identify how to treat these patients, how to treat them effectively.
And so you come up with then a master plan then for that person. And then I guess, and how long will they be with CognitiveFX?
You know, typically, Sherry, our average patient is about 2 weeks. They're about 2 weeks. Now, in some cases, we have a patient that is there for just 1 week. But for the most part, what we found is that 2 weeks provides the best outcomes, and 1 week really, we also have great outcomes, but there's a lot more attention to what they have to do post-care wise.
Okay,
they have to
so
follow their post-care recommendations much more carefully.
yeah, so there's a 1 to 2 week time with CognitiveFX in the office, and then there's homework that goes home with that. And what's the follow-up like after that?
So, you know, we know when these patients come to us, Sherry, to be honest, you know, we're usually their last resort. You know, people don't usually pick up and fly across the country and, you know, come to this clinic in Utah, you know, a week after their concussion. You know, we usually try to say, stay close to where you are, try to get all the resources around you. So by the time they come to us, they are, you know, they've been struggling for months, years, decades, and they feel so isolated and alone. Part of the healing is coming to a place like this where we understand you. You're here with almost 20 other people every week that get it, that are struggling just like you. And so the worst thing we could do is just cut someone off, right? Okay, you're done with your 2 weeks. See ya. You're gone. We don't do that. You know, we extend this relationship with them for as long as they need to. But typically, you know, patients will be contacted 2 weeks after their time with us. And then about a month after that, and then about 6 months after that, and then about a year after that.
Okay.
Yeah. So and for the reason we check in, I mean, we have a whole staff group called patient care coordinators, or PCCs, that take their hand through that process. And, we're always here to answer any questions. In the unfortunate event that a patient maybe gets another concussion afterward, they can be brought right back into the clinic, with the help of those PCCs. And we actually have several PCCs, patient care coordinators, that are brain coaches. There are traumatic brain injury coaches that they can, on the side, that they can actually help patients that might want that extra care.
Yeah, we've talked in this realm, and I know you know better than anybody, right? Having seen it firsthand, that there's a significant gap for acute after the acute care for a brain injury. And so there, the fact that there's this long-term, even after the acute care, you might go to some rehab, right? But the long-term care that CognitiveFX provides, it seems to be very unique in the market for any type of other therapies that's out there. Dr. Fong, what is from a patient that can benefit from your type of service, kind of what sort of things should, if they're the people who are on this and are going to see this, they're trying to evaluate whether or not CognitiveFX would be a fit. What are some of the symptoms or challenges that they face that might make them a good fit, and how could they evaluate?
Okay, so one of the things that I would really recommend looking at and taking kind of a deeper dive is what happens when you exercise. Do you notice that you're not exercising like you used to? You don't have that same physical drive or desire. It's very easy to say, oh, maybe that's just depression, right? And maybe it is. And who wouldn't be depressed if you're living with an injury like this for as long as you have been, right? But what I want to kind of draw your listeners' attention to is something called dysautonomia. Okay, and this is relatively new in the concussion kind of world here, where we understand that the body and the brain can feel under attack. When you've had a number of concussions, or if you've had a concussion and you're still struggling with these symptoms for years and months and years, the body just gets tired. It feels like it's almost in survival mode all the time. And that dysautonomia can come on and be triggered by things that you're not even aware of. So let me break it down this way. The brain is comprised so the central nervous system is your brain and your spinal cord, okay? And in your central nervous system, you have what's called the autonomic nervous system. And autonomic sounds like automatic. So you just kind of think of things that we automatically do without thinking, like breathing, okay? Yeah. Blood pressure, heart rate, body temperature regulation, and so on. Well, in patients that have dysautonomia after traumatic brain injury, their brain kind of always feels like it's in fight or flight or kind of survival mode. And so you have a brain and a body that is just constantly on, kind of hyper vigilant. And even something like a little bit of exercise, getting your heart rate up, which should be healthy for us, and it is healthy for us, the brain says, oh no, why is my heart rate increasing? Are we running from that bear? Is it go time? And it can misinterpret that. And then a patient can become very, very symptomatic. You could even have a patient who, can't sleep at night, and they might notice, gosh, I'm waking up so much in the night. I'm not sleeping. Why am I waking up? Well, it could be that your brain is actually hearing noises, and rather than just going, oh, it's nothing, just go ahead and sleep, it's going, oh my gosh, something's going on. Who's coming in? Who's breaking in? The brain is all about survival. And as smart as our brain is, it can kind of be dumb sometimes. And it can do things that just, really wear us out and make us tired because it doesn't know how to turn off, because it's all about survival. So yeah. Those are some of the things I think get that misdiagnosed, or patients will then go to their cardiologist because they think my heart keeps racing. I don't know what's going on. They go to the cardiologist. Cardiologist does all their tests and they're like, oh, you're fine. They'll say, wow, I'm getting dizzy when I lay down and when I stand up. They'll go to their doctor and they'll diagnose them with POTS, and you might go to their psychologist because you're down all the time. They'll diagnose you with this and this. The problem is that all these healthcare institutions are siloed, and they're not really talking to each other, and they're not maybe understanding what the root cause is. And that root cause might have been that traumatic brain injury, maybe a ton of years ago, right? That the pieces just aren't falling in together into the puzzle correctly.
Do you see patients, Dr. Fong, that maybe feel like they've recovered from their brain injury, but as you age, the root causes, they've never really gone away, right? They've just learned to moderate it or work around it. But do you see a lot of patients that feel like they've had somewhat of a stable system, but as they've aged or another trauma has happened, maybe COVID has come along, which we've heard about, has sort of triggered some of these other things, or there's another injury or illness of that type? I mean, do you experience that?
Every day, every day, Sherry. So we often have patients. Let's kind of go back. We'll kind of go through the years, through the lifespan. Okay, so we often have patients that are, children, right? And children, we used to think, oh, it's better if you get a concussion when you're a child because then your brain will just adapt and you'll be fine when you grow older. And actually what we found with our imaging and with our treatment is that children's brains are so plastic and there's so much neurogenesis going on that sometimes the brain can cover up some symptoms pretty quickly and pretty easily. But the problem is once they hit puberty or once they hit more development, then the brain can be thrown off again. And we have patients that are young that can be again symptomatic,
Mm-hmm.
And so they're kind of a harder kind of puzzle to put together because there's family dynamics as well. There's school, there's, boyfriend and girlfriend, stressors and situations that can really kind of complicate a child's picture or an adolescent or a teen's picture. So yes, we can see where they might feel like they recovered, but then they might hit puberty and things kind of go downhill. And then we'll see them. Then we have these patients that are kind of in their 20s. Okay, so let's talk about lifespan here. So they're in their 20s, they feel like they're on top of the world, they get a concussion, and then they're like, yeah, but I'm fine. Again, if you're in your early 20s, you're still really relying on that neuroplasticity and that neurogenesis, and they kind of feel on top of the world, and that kind of covers things up for a bit. Unfortunately, for a lot of our 20-year-olds, they're also engaging in a lot of alcohol and other, drugs and other things like that are actually doing more harm to their brain, but they don't really realize that too. So as the brain starts to age, we usually see these patients around the age of 28, 29. And they're coming to my office going, I know I had these concussions, but I was fine. But then all of a sudden, I'm 28, 29, and I don't function the same anymore. And they're like, I don't know what's going on. And I say, well, I think I might know what's going on, right? Because about 28, after about the age of 26, we really don't have that much neuroplasticity and neurogenesis. Our brain kind of finishes off its development about that time. And so all that extra reserve that you had to kind of keep you going kind of stops at about that age, right? And so that's when we get our patients in. I'm like, well, yep, now you're dealing with the brain that you have, right? And now let's figure out how to fix that. Now, throughout the lifespan, let's keep going. Typically, we can get patients who, once they're kind of in their 30s, 40s, 50s, if they get that single concussion, their brain is not healing like it did before. And they're in my office saying, okay, I had this one concussion, I'm not the same, okay? But then they might have COVID. And COVID, in some cases, especially if you have a brain injury, having a brain injury or a prior injury, and then having COVID really sets you up for a greater risk to have long hauler symptoms, okay? So we'll have patients coming in with kind of more complicated cases and kind of a viral load on top of a brain injury. And that can happen throughout the lifespan. And then my favorite ones really are patients that are in their 70s and their 80s who were really, really sharp before, they've run their own businesses, they've, been able to be really successful. And then they're having some memory problems as they're aging. They go to their neurologist and the neurologist says, yeah, I think you might, maybe having some early signs of dementia. Those are my favorite ones to bring in because if we can scan them and we can see that that there are some traumatic brain injury biomarkers, we can treat them, maybe take away those concussion layers, and because maybe they had a concussion years ago and their brain just compensated, but then they reach an age where their brain doesn't want to compensate anymore. When we do treatment, we've seen in so many occasions where after treatment, they no longer meet the criteria for dementia or mild cognitive impairment. And we just kind of took that diagnosis off their plate, because it was a lingering brain injury. So that's a really long answer to your short question about what we see, but I hope that elucidates what can happen throughout the lifespan and what these TBIs can do.
Yeah, I think it's super helpful for you to explain that, because it's not a, you think you've recovered from that. I don't think that point is very well understood, that a concussion or a brain injury will have long-term effects, that it is cumulative, right? The impact of that can be cumulative over the lifespan when you add these other factors of normal life into that. And so we've talked a lot about brain injury and I mentioned PTSD in your earlier experience when you were doing your residency a little bit as one of your passions. But yeah. I know that you mentioned that you were looking at maybe expanding that what CognitiveFX does beyond sort of brain injury into some other areas. And you had mentioned that stroke was one of the areas that you looked at, and then also looking forward, maybe working on some ADHD and other sort of childhood challenges like anxiety as well.
Yes, and even autism, that's something that we're really looking at. Yes, I think that we're really just kind of scratching the surface as to what these advanced neuroimaging techniques can show us, right? Really, fMRI is having its heyday, even though fMRI has been used for decades by neurosurgeons. They would help neurosurgeons determine, what parts of the brain were active, which parts weren't, which parts they could cut, which parts they shouldn't touch, so it's been used clinically for decades. But we're really now kind of in this golden age of seeing how these different types of imaging modalities can help track symptom severity, how they can help us figure out what's really going on, even combining different modalities like diffusion tensor imaging, which is called DTI, or susceptibility weighted imaging, which is SWI. I think that there's no limit to what we can see with brain function and applying that clinically. And so, one of the things I really want to do is look at ADHD, especially maybe some of those that maybe are borderline or high functioning, and seeing if we can make subtle changes to brain wiring, if they don't need medications, right? I mean, if you know anything what's going on in the ADHD realm, it's really, really hard to get your hands on Ritalin and Adderall and other types of stimulants right now. It is being prescribed at such a high rate, it's really hard to get them. And so you have people that I think are being misdiagnosed with that, or maybe are wanting medications like that for other reasons. And the people who really need it are not able to get it, But what if we can help some of these people reach the same goals without medication? That would be huge, right? And even in the autism world, again, focusing on some of those that may be more higher functioning. What if there are biomarkers that we're seeing with functional MRI, and we can treat those and help them, be able to live more fulfilling and more productive lives, without any sort of medications or anything like that. That would be my goal. But the sky, I think, is limitless on this.
So what are your plans to integrate that into CognitiveFX? What's the timing around that?
My goal is to get some sort of an attention deficit disorder protocol in sometime this year. And I think we're also going to be working on an autism portion as well sometime this year. Implementation might not be till next year, but that my goal would be to get something started this year and at least run some pilots, which we have been doing already.
Yeah, that sounds amazing. I mentioned that my daughter suffers with ADHD, and one of the challenges that it's not that we can't get the medication; none of them work. They've all had some serious side effects, and so I think coming up with a protocol that would eliminate the ADHD symptoms without the need for medication in general. There's a whole population around that, just who there's not really any, other than supplements that kind of help address that. So that's a huge need, and I may be one of your, or my family may be one of your patients in the future. You can call on us.
You're welcome, Sherry, anytime.
Well, Dr. Fong, thank you for explaining all of that. And I think everybody now has a pretty good idea of what CognitiveFX does, how it works. And I know that you do that brain imaging in the beginning, but you also do it at the post-treatment to sort of understand where they are too. And we didn't talk a little bit about that. Do you want to mention anything on that before we move into the exercise?
Yeah, I would love to. In fact, can I show you an fMRI? Would that help?
Oh, great. Yeah, if you
Yes.
have it, you go ahead. You can share your screen and take control.
Okay. And I know that there's some questions here as well, Sherry, that maybe I can answer while I'm pulling this up. How do you do cognitive tasks during fMRI? Doesn't the patient need to be still? 100% correct. So what we did was we actually adapted some neuropsychological paper pencil tests into the MRI environment. So we have the patient is lying supine in the MRI machine, but they're shown a screen that shows some stimuli. They do 3 different tests while they're in the MRI machine, and we have them actually respond by using what we call a fiber optic response pad, which is a FORP. We call it a FORP, fiber optic response pad. And they can answer questions either 1 through 4 or yes or no based on that response pad. But yes, it is very, very imperative for that patient to be as still as possible while they're doing this scan. I hope that answers that question. Let me see.
Before you move on to the next question,
Sure.
that, Brian Johnson is developing his mobile imaging system. Is that something that you've looked at using? I think that would maybe help maybe eliminate the need for some of the stillness around that.
I'm not quite sure about what that is. And so I would need more information to be able to answer that. But, we are also doing some research with something called fNIRS, which is called functional near infrared spectroscopy. It's kind of a mouthful.
That is a mouthful.
Yes, but we are actually doing some pilot studies with it now to try to see if that can correlate with our fMRI. And the nice thing about fNIRS is that this is something that can be done, that they can wear and we can track while they're doing therapies. So for example, we can track in real time what someone might be doing during a cognitive therapy session, for example. So we can see if the parts of the brain that we hope are changing or that we want to change are actually getting activated in real time.
So that's amazing.
Yeah. Can you see my screen, Sherry?
Yeah, I sure can. Yeah.
Okay, great. So this is a redacted scan. So we don't have any patient information on here, but this is an example of what an fMRI report looks like, right? So, and I often get some patients say, well, I saw on television that you actually had the brain and it lights up. And I'm like, yes, that is for television. And that is for, when we publish. But when we look at actual data, this is what we're looking at. So this right here on the right-hand side, these are 27 what we call biomarkers or functional systems that we are measuring. So these are 27 different tasks that we are looking at while you're doing these 3 different neuropsychological tests in the scanner. You can see a break between the line, between the graphs here, and this means this is the first test, this is the second, and this is the third test. For the first test, they're doing what we call a progressive matrices test. So it's a nonverbal problem-solving test. And what this shows overall is, for example, in target search or visual feature detection or visual spatial mapping, this is kind of a cumulative score looking at not just how the different parts of the brain respond, but how well those parts of the brain are communicating with each other when they're doing a particular task, okay? And what in general, we want these lines to be as close to the green and as far into the green as possible. So we can see here that on this first task, Jane Doe didn't do so well. We had several areas here where her activations are in the red. And the other thing is that her activations are very choppy, meaning you have some areas here and kind of move this way and then this way. They're very varied, okay? Whereas a healthy brain will have activations that are here in the green, but they'll kind of line up like this, and they're much closer together, so there isn't as much variation in the scan. So this tells me right away that her system here to do this nonverbal problem-solving task is very depleted, it's very difficult, and it's very inefficient. So what we do, Sherry, is for each one of these these functional systems scores, we break them down one by one. So for example, this is the first system. So we get kind of more in depth and more in detail. So this top graph here looks at all these different regions of the brain that we know are activated when they do this task, okay? And we know because we've done tons of control studies, so we know what normal looks like, okay? And that allows us to be able to make these individual scores more meaningful. So what we see here are region response. So I can see all of these different parts of the brain, okay, here, like left caudal middle frontal, right caudal middle frontal, left precentral, right precentral. Yeah. And I can see how well these structures are metabolizing energy. Let me take a quick step back, Sherry, if it's okay.
Yeah.
The brain is just the most fascinating organism in our multiverse. And I got that from one of our past patients who was a literal rocket scientist working out at the, in Florida at NASA. And he said, I can verify that the brain is the most magnificent organism and complex organism in the multiverse. And I agree with him. Okay. Our brain fires. We have neurons that fire, right? That is how our brain sends information from one neuron to the next. It's like electricity, it just kind of fires. But neurons, as wonderful and as smart as they are, they do not have their own internal fuel source. So in order for a neuron to fire, Sherry, it has to get gas. And it gets gas from blood. All right. And it's much more complicated than that, but really this is the basics, is that blood carries certain energy metabolites, namely oxygen and glucose. So the cool thing that fMRI does is that fMRI is a big magnet. And there's a subtle difference in magnetic properties between oxygenated and deoxygenated blood. So there's a difference in the magnetic property when that neuron goes, oh, there's blood, I'm going to take that and use it and fire. So what the fMRI is capturing is that moment when that neuron sucks up that blood, deoxygenizes it because it needs it, and then fires. Okay.
Yeah, this is fascinating that you're able
so
to
cool?
get to that. Yeah, it's fascinating. I mean, it really breaks down the science of how you're doing what you're doing.
Mm-hmm. That's right. And it's, you know, it's quite simple when you think of it that way. And what this first scan shows, Sherry, is the further we go to the left, the less firing there is. There's not a lot of that the oxygenated to deoxygenated kind of gas guzzling going on. So this is a brain that is what we call hypoactivated. So the brain is not getting the glucose and the oxygen. It's not firing like a normal brain should. It's like it's running on fumes. It's like a car that's just running on fumes, okay? And when I say that, we usually have patients say, oh my gosh, that's exactly how I feel. Oh, you know, I just don't have enough energy throughout the day. And I'll say, well, yes, absolutely. I mean, especially look at this one right here, this left supramarginal gyrus. And we actually have it right here, posted right here, okay? So you can see that the bluer that structure, the less active it is, okay? So you can see across the board here of all the structures that we're looking at, there's a lot of hypoactivation, okay? So that's what that first graph tells us. Now in the second graph, what I'm looking at now is what we call communication. How these different structures up here are talking to each other. And so what we see here, can you see this one that's way on the right-hand side here?
Yeah, is that going to be hyper?
Yes, see, you're an fMRI expert already. So Sherry, what we're seeing here is that we have two people here, and I like to say it like this. There's two girls in the back of the class that are gossiping and talking way too much, and they're distracting the whole rest of the class, okay? And that teacher has to pay a lot of attention to those two because they are just sucking all the energy, right? Well, that's what's happening here functionally, is that you have these two structures that are over communicating or over relying on each other because they're both pretty hypoactive. So they're going, hey, I'm hypoactive. Are you? Yeah, I am. What are we going to do? We need to really help each other, you know? And so we have this kind of compensation or compensatory strategy that's happening because a lot of these other areas are not firing enough. And so can you imagine the validation this is to a patient that says, oh my gosh, all my other scans are normal, and I'm finally seeing something that shows that I'm not normal?
Yes, I mean, it's a sense of relief to know that what they've been expressing, there's some sort of academic data to support that, which changes not only, you know, their perspective, but everybody around them, because so many people going through this, you know, they can function on a day-to-day basis, but they're not themselves. And people, you know, the caregiver perspective and the family dynamic, you know, they don't understand it because they can see them doing, you know, a functioning on a day-to-day basis in somewhat normal standards. So I love this. I love it so much.
And, you know, I would also add that, you know, the patients themselves start to doubt themselves, right? I mean, if everyone around them saying, you should be fine, sometimes, I mean, a lot of times we have patients going, maybe I am crazy. Maybe this isn't my head because everyone says I should be, you know, what's going on with me? So there's a lot of self-doubt that happens, you know, and I think that is probably one of the most sad things, is to see some patients come in here and just break down and cry because they finally feel that validation that, okay, I'm not crazy. There's really something going on. And I just want to let you know that this Jane Doe did very well on a paper pencil neuropsychological test, right? Just done like a, you know, her IQ score was fine. Her, you know, her memory was all within normal limits. Now, of course, this is someone that was higher functioning before, but the problem is if you start up here and now you have a concussion and you're down here, but average is here, normal's here, you're also not going to get any sympathy because now you're just like everybody else. But that patient feels that loss of functioning so much more acutely, right? And it can be really psychologically and emotionally damaging to that person as well. And we have to pay attention to those psychological effects with these patients.
Yeah, I think that's extremely important there too. And it's kind of this really highlights the other thing that's jumping out as me as, or to me, is that, you know, so many patients just don't have the energy as you're talking about because of the damage. And so therefore they can't progress in the other exercises. So it's one of the things from your principles or your treatment principle is you've got to sort of address the energy components first and then work on, you know, repairing maybe or addressing some of the other functionality.
Yes. And so what this scan does, right? Number one, I just want to be clear. We don't use it to diagnose. We don't need it to diagnose. Most people come to me and they already have a diagnosis, or I can just diagnose them just talking to them and having them, you know, answer some questions in a really thorough clinical interview, right? So we don't use this to diagnose. What we really use this for is to track symptom severity. Okay, so we use this to really kind of track their symptoms and to really see how they're responding to treatment. Okay, so with regards to treatment, you know, we really try to get this. Thank you. Did you take it off screen share?
I did, because we
thank you so much.
see your face. Yeah.
Oh, no, okay, sorry. Yeah. So, you know, we know that the brain is the root of everything, right? The root control that the brain controls really everything in the body, almost everything, and the central nervous system. And so we have to identify what the root of that problem is. Once we identify that root, all these different brain regions correlate to different neural function and different motor functioning, et cetera.
Yeah.
And so our job really is to open up windows of neuroplasticity, because, you know, the older you get, it's kind of harder to open up these windows of neuroplasticity. But neuroplasticity is real and it can happen across the lifespan. But there are certain tricks and tips to get that brain to open up so we can open up that hood and start tinkering around inside. But yes, we have to get to the bottom neurovascularly, and then we can do a lot of the more physical and more of the functional treatments after that.
You know, you mentioned that Jane Doe, that patient that you just talked about, did well on a typical psych eval assessment. Are there, is anybody, are you or is anybody out there really working to try and change that psych eval so that these sorts of things can be integrated and identified? That to me seems like one of the things, just as a whole, holistically, we need to do to try to help, you know, help validate these individuals, and that's something that can change. I would imagine at an easy level, but maybe not.
Oh, you're asking the golden question, Sherry. I mean, I wish some brilliant neuropsych student would come up through the ranks and figure something out, right? Because the truth. So let me just kind of give you a brief history of neuropsych assessment. Okay. Neuropsych assessment was actually developed in the 1800s. And the reason it was developed was because we did not have neuroimaging. It wasn't even thought of, you know? So we had to figure out ways to try to assess what parts of the brain were injured during a brain injury. Okay. And so, you know, these brilliant neuropsychologists of their time crafted these tests that you know, with where they knew, okay, the frontal part, you know, when someone was injured here in this part, they were more impulsive. They lost, you know, the ability to reason. So they were kind of working backwards in a way, right? But when you think about it, a lot of these tests were created, number one, before we had any neuroimaging. And number two, they were really meant for a more serious population. Not saying that MTBI isn't serious, but a lot of these tests were normed on people that had severe traumatic brain injury, or they had part of their brain resected, okay? And so it's not sensitive or specific enough for this higher functioning population. So, I mean, I do know that there are some people out there trying to, you know, modify some tests. In fact, one of my mentors, his name is Dr. Aaron Bigler, he actually, you know, in partnership with some other researchers, tried to kind of take down some of these tests that were being used to qualify these traumatic brain injury patients as malingerers or fakers. So for example, you know, unfortunately, a lot of these traumatic brain injury patients are involved in lawsuits. And it can become very adversarial when you're dealing with, you know, a defense attorney or whatnot. And their job is to try to make that patient look like they're either faking or that it's not real, the traumatic brain injury is not real. And so there were tests that were being used that say, oh, look, you know, they're not valid. They're saying, they're indicating on this test that they see things that other people don't see, or they're hearing things that other people don't hear. They're not traumatic brain injury, they're schizophrenic, you know? Whereas if you talk to anybody with a TBI, yeah, they have ringing in their ears that nobody else can hear, okay? They have visual floaters that nobody else can see, right? They might have double vision or blurry vision, but they were just answering these questions as honestly as possible, but then they're being categorized as a psychiatric patient or a malingerer, you know? And so there needs to be a revamping, I believe, of the paper pencil neuropsych world. But I think that the world also has to understand that the purpose of neuropsych is different because now we have neuroimaging too. Okay, so that's a very, again, long answer to your short question.
Yeah, I mean, I think that's something that NPA would like to try to help challenge. I know it's an area that is constantly coming up in all of these seminars and interviews that we do, and to try to help get to that root cause, help identify it early on, so people don't have to go for decades as they do, and you know, and find neuroplasticity and therapies like yours, you know, after you know, years and years have gone by. So that's certainly something that we're taking a look at. So Dr. Fong, just being cognizant, we're running a little bit out of time here, but I do want you to, and we're going to come back to these questions, everybody. I know there's some questions there, but I know you had an exercise you wanted to share, and I think it's a good time.
Okay. Do you mind if I share my screen again?
Please, go ahead.
Okay, so let's see if I can do this here. Okay, I'm going to Sorry. Second
That's
share
okay, take your time.
screen. Okay, here. Can you see this breathing exercise right here?
Yes.
Okay. So we can do this pretty quickly, right? The reason why, let me go take a step back. The reason why I want to do this breathing protocol is because this is one of the things that someone can easily do at home, and they can determine if dysautonomia is kind of a problem for them. And we do this with almost every patient that comes into our clinic. Because the autonomic nervous system controls breathing, we may not even be aware that that we might be breathing incorrectly. Okay, so what I want you to do, okay, is first of all, place one hand across the base of your ribs right here. So just kind of like in the picture. Okay, so you have one hand placed right at the bottom of the ribs. Okay, and I want you to place the other hand across the top of your chest. Okay, you want your upper hand on your chest to not move very much, but you want your lower hand that's on your ribs to really move the most. So I want you to try to breathe for 7 seconds. Okay, so I want you to breathe. Okay, breathe in through your nose. Now, if you're noticing that your chest, that your top hand is moving, that means that you're breathing your what you call your parasympathetic nervous system, okay, is not really in control. Your sympathetic is doing all the work, okay? So we really want you to kind of disengage that fight or flight. So breathe, try to keep your chest not moving, and try to get your diaphragmatic breathing to kick in. Okay, so, okay, breathe for 7 seconds. Let's practice this. 2, 3, 4, 5, 6. Now take a deep breath in and hold your breath for 3 seconds. 1, 2, 3. Now slowly exhale through your mouth for as long as you can. Okay, let's do that again. Let's breathe again for 7 seconds through our nose. Try not to have your upper hand move, more your diaphragm. Okay, so let's start breathing in and out, 7 seconds. 1, 2, 3, 4, 5, 6, deep breath, 7, and then hold your breath for 3 seconds. 1, 2, 3. Slowly exhale through your mouth for as long as you can. Let's try one more time. Start again, breathing, 7 seconds. 1, 2, 3, 4, 5, 6, 7. Now hold your breath, 3 seconds. 1, 2, 3. And then again, exhale through your mouth slowly for as long as you can. So, Sherry, what did you feel in just that
Well,
exercise?
yeah, my chest was moving more.
Mm-hmm.
Yeah.
Yeah. What happened when you switched that to where you're breathing from your diaphragm?
It was a deeper breath.
Mm-hmm.
And yeah, I felt more calm.
Exactly. Because we're triggering that parasympathetic to come in and just take over. One of the things you might notice is if you're a mouth breather, okay, so if you breathe through your mouth, that's shallow breathing. When you're mouth breathing, that is sympathetic fight or flight breathing. So if you catch yourself mouth breathing, what we want you to do is close your mouth, breathe in through your nose, because when you breathe in through your nose, that is actually parasympathetic breathing. That is the rest and digest breathing. So even just switching your breathing can force your body to calm down if you're in a fight or flight type of a dysautonomia reaction. So this is something you can easily do at home, at any place, anytime, and very inconspicuously. Okay, that is one that I would really recommend. Here are some other ones as well. Box breathing. So again, breathing through your nose, okay, and out through your mouth, but you can breathe in for 5 seconds, hold for 5 seconds, breathe out for 5 seconds, and repeat. And another one is just regulated breathing, just mindfully practicing breathing in evenly in and out for 5 minutes, but make sure that it's coming from your diaphragm. So those are just some other quick ones, but I like this one here because it helps you focus on where you should be having that movement come from.
Yeah, that's really helpful. Thank you. We got a couple of questions, and maybe we'll put this back up, or your contact information at the end.
Okay,
but
great.
I had a couple of questions. I think it might be helpful just to see you. So maybe if you want to stop sharing for
Sure.
just a second. I did have a question about the breathing, and it was, is your diaphragm supposed to move?
Yes. So your diaphragm, right? If you breathe from down here, your diaphragm should be kind of moving in and out and in and out. So that's what you should be feeling, those deeper breaths.
Okay. All right. A couple of other questions that we have here is that, can imaging trace the source of brain pain?
Sometimes it can, but really, we have a really wonderful blog that talks about all these different types of pain that can happen in your brain and in your head, that I can make sure that we send you, Sherry, and then you can disseminate that out. But, there are times where we have identified, so we not only do we do functional MRI, but we also do structural, because we just want to make sure we're not missing anything organic, right? We're not missing a tumor or something else. But there are times when a patient says, I have pain kind of right, and they kind of triangulate it like this. And then when we look on the structural scan, we actually find something that we didn't know was there before,
Mm-hmm.
So yes, that can happen. But most of the time when someone says there's brain pain, it's usually kind of more global. And we see that when we see neurovascular dysregulation. So for example, like in that functional MRI that I showed you, and I remember how I showed you how all of those structures were hypoactivated.
Yeah.
Sometimes that patient would be like, it's just this dull ache. It's here, but we find that it's neurovascularly related, because when we do our treatment and we get the brain to rewire, oftentimes that pressure or that headache can dissipate. But headache is usually, it's one of those tough ones, and it's usually multifactorial, and neurovascular changes are just one factor.
Okay. And there's been a couple of questions about whether this is going to be available afterwards. Yes, it is. And if Dr. Fong's okay, we'll send out the breathing exercise, as well as a link to the blog that she's mentioned. So all of that will be available. Was the list of 27 tasks on your website? I think those were the tasks that were in that.
The functional systems,
yeah.
27 biomarkers. I don't know. I don't know if they are or not. That's something that we really just kind of have in-house in clinic, but it's something that we could put on our website. I don't know if it is.
Yeah. Could we possibly send out that redacted fMRI
Sure.
report?
Yeah.
Is that something we could do? Okay, great. Yeah.
Totally.
So I'll include that. So a couple of other questions here. Will neuroimaging fMRI show cognitive decline based on the progression of a rare movement disorder called orthostatic tremor?
I don't know. And that's my honest answer. I don't know.
Okay.
You're more than welcome to, talk to us about things. I'll have to do more research on that. But if you're noticing cognitive decline and we can see it on fMRI, then I'd love to try to help treat that. But my gut instinct would be, yes, if you're noticing that you are having some cognitive decline, the fMRI does usually pick that out. But I don't know. We've never done that.
There are a couple of questions here, Dr. Fong, about cost for the treatment, and I think maybe we can talk a little bit about insurance coverage as well. Do you want to just sort of
Sure.
Answer those in a general way?
So the scan in and of itself is $3,500. The full treatment for 1 week, and that includes the scan price, is $13,000. That includes your first fMRI at the beginning of the week, the second fMRI at the end of the week, a structural MRI of your brain and a structural MRI of your neck, as well as the full week of treatment. Okay, and you're talking 9 to 5, 8 to 5, one-on-one therapies, throughout the entire day, except for lunch. a 2-week program, which, like I said, we're moving more towards because we get better outcomes. Instead of it being 13 plus 13, it ends up being 24,700. But that also includes all the imaging, but 2 full weeks of treatment. And then we also do, that includes the post-care and the aftercare too. So now with regards to insurance, we personally don't take insurance. However, we do provide you with a super bill that you can then go and collect from your insurance company. And most insurance companies are reimbursing about 70 to 80%, but we can't guarantee that. They reimburse some parts of it, especially because most of the therapies are all insurance reimbursable therapies: speech therapy, cognitive therapy, physical therapy, occupational therapy, neuromuscular therapy, vision, vestibular, psych, and so on. But some people go get pre-authorized first from their insurance company and whatnot. So, but we have wonderful logistics specialists that can walk you through that process.
Okay, perfect. Yeah, that's great. That's great. And I think, well, let's see, it's about 10 after. I've got a couple of other questions here, and maybe we'll just get some, well, it's 2. Let's just try to get through them real quick. Do you mostly work with high functioning individuals? Do you have any scans of patients that you turn away because they're too complex or dependent? I think that's a fair question, really.
That is a fair question.
Yeah.
Yes. And so some of the limitations with fMRI is that you need to have at least a 3rd grade level of ability. Okay. So we actually don't really treat kids younger than the age of 8 unless they're just a really bright 7-year-old, because you have to understand what we're asking. You have to do the test. You have to respond appropriately. One of the other criteria is, we do see stroke patients, but usually they have to be a bit higher functioning. It's very difficult to work with a patient that may have a receptive or expressive aphasia, again, because we need to know that you're understanding what we're saying and that you can give back, a response. We run the gamut. We've treated patients with long haul COVID. Okay, we love those patients because they look so similar to concussions. So concussions, long hauler COVID. We've treated patients with stroke that maybe are a bit milder. We've treated patients with motoric issues after a stroke. So let's say, it was a left hemisphere stroke and they have trouble with their right side. We will still treat you as long as you can cognitively still understand what we're asking of you. We've treated patients with encephalitis. I see on here rabies encephalitis. Again, one of these issues are if they can do the scan validly, then we will attempt to treat them. Neurotoxicity, mold, carbon monoxide poisoning, etc. So we've treated pretty much every neurological condition, but they do have to meet that minimum requirement of being about at a 3rd grade level.
Okay, I think that really sort of answers those questions. And I think maybe, well, I'm assuming you guys have a process for when somebody, there's a lot of questions about, what about this situation and that situation.
Mm-hmm.
And I'm sure that you have representatives there that can help sort of, go through that at a high level to determine whether it's a good fit, right?
That's right. That's right.
Yeah. And so I think at this point, we can just put up your contact information and they can reach you there. So let's go ahead and do that. Thank you, Dr. Fong.
Mm-hmm.
And you can take a few minutes and scan that with your phone. Get that information.
And Sherry, we can send all this to you, and so you can disseminate this to your listeners as you wish. But we'll include that fMRI report. Can I show you real quickly again what her scan looked like after treatment as well? Because I think that's important to see.
Oh, that would be great to do. I do. Yeah, I think that's perfect.
Okay, so let me just show you that real quickly. So after a week of treatment, okay, let me share my screen again. So after a week of treatment, this is what her scan looked like. So you can see.
Wow.
Yeah.
Wow.
Quickly, this is after 2 weeks, not just one. So this is after 2 weeks of treatment. You can see all those areas that were in the red have moved to the green. These areas were right here before, and they just got even greener. And these areas also got greener. And so that's the beauty of this, Sherry, is that when we're dealing with an overall healthy brain, right? We're dealing with a brain, like I said, that looks pretty normal very normal on structural MRI. We have a brain that's ready for change. People ask, how can you do this in 2 weeks or 1 to 2 weeks? And I say, because we're dealing with a healthy brain. All we're doing is teaching that brain to utilize energy more efficiently. So for example, an example that I like to share is, it's almost like when you had that injury, the freeway was busted. Okay, so you had to find alternate routes. Your brain had to find alternate routes to get around because it couldn't take the freeway anymore. Well, with these concussion or these long hauler cases, especially if it's been months to years to decades, well, the freeway's there now. The inflammation's gone, right? The brain is healthy overall. But as smart as that brain is, remember I said sometimes your brain's kind of dumb. It does not reroute itself to the freeway. It'll continue to use those alternate routes, okay? Just because that's what it's going to do. Oh, we got to reroute. Okay, this is how we're going forever now. My job is to say, hey, that freeway is open. So let's go back to using this freeway, okay? And then the brain goes, oh, it's open. Okay, let's use that freeway again. So that is why we can make these changes so quickly, because we're dealing with a brain that is plastic, right? We're opening up these windows of neuroplasticity. The brain is plastic and it wants to change, and we are just rerouting. We're re-GPSing. We're finding the faster, quicker route.
Yeah, you're the Waze.
Yeah. Yes.
Oh, well, Dr. Fong, thank you so much for joining us today. Sorry about the little snafu at the beginning, but you got here and you shared so much information, and I really am excited about what you're doing there with CognitiveFX, and I'm really looking forward to see how you translate that into some childhood development challenges, and we'll keep posted on that. Maybe we can have you on again when that protocol is ready. We can talk about that.
I'd love it.
Yeah, sounds great. Well, I will, just for everyone here, we will be putting this out. I will be sending it out. There'll be a recording on our YouTube channel. And I will be emailing everybody the breathing exercises and the other items. So stay tuned for your inbox for that. And please reach out to CognitiveFX if you think that they can help you with any of your challenges. We look forward to seeing you back here tomorrow at 12 noon. For another Lunch and Learn series, and we will be hosting let me see, tomorrow I believe is Dr. John Hartman, who is using the Bears protocol in his practice. So we'll talk a little bit about that for, again, focus on long COVID and brain injury. So that's it. That's a wrap for today. Thank you again, Dr. Fong.
Thank you so much, Sherry.
Okay.
Bye, everyone. Thank you.
Bye-bye.